Our discussion today is about substance use disorders. We're going to first talk about the basic considerations of substance use disorders. When we use the terminology drug abuse, typically it means that someone is using a drug that is inconsistent with the medical use or within the social norms. And traditionally, it implies that the drug being used is harmful to the individual and overall to society. Now, we can give abuse a general definition. Whether it's a particular instance of drug use that could constitute abuse, or is it long-term instance of drug use. So it's kind of often difficult to really define this term. And whether or not the drug is considered abuse depends on what the purpose of the drug was taken for in the first place. And so not everyone takes large doses of psychoactive agents and other medications, and we would call it a disorder. So for an example, if we consider drug abuse to take place in our society as someone taking large doses of opioids for pain relief, maybe it's caused by cancer. So it's not really the quantity, rather than was it used in a way that is unhealthy for the individual, or again, something that isn't within the norm of medical treatment. But these same opioids, even used in a lower dose, if it's without the outside the boundaries of medical use, then even lower doses producing euphoria could be considered abuse. And it can have different severities. So some people use heroin occasionally, other people use it habitually and compulsively, and we can say this about other psychoactive drugs. We can even say it about marijuana. Although both patterns of drug use are condemned within our society, we would say it's abuse. There is obviously a quantitative difference between heroin twice a day routinely versus twice a year or compulsively. Because abuse is culturally defined and our different societies and our cultures, they differ from one another, we use this term interchangeably. Sometimes with drug addiction, someone that is constantly taking a particular drug because they are feeding into that compulsive drug seeking behavior, and they are using it even though they understand the harmful consequences. When we use the term drug addiction, we're thinking in terms of something being chronic. So because in this pharmacological textbook that we are using, and this is not a sociology class and we're not using a sociology text, we're attempting to define patterns of drug use that do or do not constitute abuse. We're talking about whether it was used for the pharmacological properties of medical treatment versus abusing drugs, taking drugs socially, or feeding into a drug addiction. There's several factors that contribute to drug abuse. The first one is the reinforcing properties of the drug. So think about, firstly, drugs are taken because it is providing a pleasurable experience for that individual. Think about cocaine producing a state of euphoria. However, there are drugs that reduce the intensity of unpleasant experiences, like the anxiety, the stress, or depression that someone might feel. And we know of these properties because there have been lab studies, and we have seen that when animals have self-administered some of these drugs, like opioids, barbiturates, cocaine, amphetamines, um, these drugs have caused these animal studies or caused these animals in the studies to develop patterns of drug use that are very similar to that which we see in humans. And animals that self administer drugs, except for nicotine and caffeine, they actually have a preference to eating, drinking, and sexual behavior. Just an interesting fact that you can read about in the, in drug studies, and especially those that are being abused. There's also a propensity for abuse in other areas of life. Um, there's some observations that actually suggest that pre-existing psychopathology isn't necessary really to start developing a drug abuse. Rather, these studies and experiments have shown that the reinforcing properties of drugs themselves actually play a bigger role. In terms of physical dependence, this is a state in which your body actually goes through withdrawal syndromes if you are using a drug and it's being discontinued. So abusing a drug and being it discontinued. And so the dependence is really largely based on the dosage and the duration of the drug itself. And physical dependence is greatest in people who take larger doses for longer amounts of time. So it's pretty reasonable to think, and there's studies to prove this. The more physically dependent your patient is, the more intense their withdrawal syndromes are going to be. And of course, there's some drugs like opioids and like morphine or heroin, and then CNS depressants like barbiturates that have more dependence or physical dependence than things that are less prominently dependent, like psychostimulants or psychedelics or even marijuana. They have less physical dependent properties. We think about psychological dependence. Sometimes it's not the physical dependence that your patient is dealing with, it's actually the psychological intense need for that drug. And these individuals that have this psychological dependence, they actually feel very strong about the sense of well-being of using that continued use of that drug. Like they have this sense of craving, and when that drug is unavailable, it actually is promoting even a more addictive behavior. These are things that we might see in the renewed use of opioids by drug addicts that have previously already gone through withdrawal. There's also the social factors, that desire for social status, fitting in. It might be the impetus for their first experience with a drug. And so getting this social approval can be one of the most compelling reasons that someone uses the drug again. And it may not only be that initial exposure, but that continuous use moving forward. Think about someone with their first cigarette. May have started with peer pressure, and then maybe they didn't smoke enough for it to have an effect. Similarly, when you think of the initial use of heroin, most often this is followed by associated nausea and vomiting. And even though these things may have been deemed unpleasant or had a negative effect on the person, this peer pressure can promote the continued use even though there were negative effects. Availability of the drug is another factor. You think about, if you can't get it, it's hard to abuse it, right? And so it really depends on what the environment is. Is it a place? Are you working in a place or community where drugs can be readily obtained? Well, you may be seeing more patients dealing with this issue. So where procurement of a particular drug is very difficult difficult in that area, then you might see less drug abuse in that area. We think about where most of us work, in environments where drugs are readily available, like hospitals and clinics. And this is really the major reason. You can look back in the news, there's actually studies that show high rate of addiction among pharmacists, nurses, physicians, and other healthcare workers. And lastly, it's the vulnerability of that individual. And so some patients are going to be more prone to becoming drug abusers than others. Think about putting two different persons in the same social setting. One may be very compelled to use a drug, and even though that initial interest, they may not ever use it again. And then there's a second person that may not even have wanted to try that drug in the first place, but peer pressure, social factors played a role, and then now they have a propensity to continue using that drug and using it more compulsively. Several psychological factors have also been associated with the tendencies toward drug abuse. And so even though this is not a sociology class or a psychology class, you want to think about all those instances and those tenets of sociology and psychology that we know, and think about that in terms of treating your patient. Lastly, even though it's not on here, I just think about it. It does fit within the vulnerability of the individual. You think about genetics contributing to drug abuse as well. For example, alcoholism. Some of us are more vulnerable to alcoholism, and this can be an inherited predisposition. Our first question to test our knowledge, it states, a patient states that the dose of oxycodone he recently received does not provide the same pain relief that it used to. So the NP will understand that the patient has developed a physical dependence, a tolerance, a withdrawal syndrome, or an addiction. If you chose tolerance, you are correct. Tolerance refers to regular use, and so it puts that person in a state where that particular dose is going to elicit a smaller therapeutic response than it did with prior use of that drug. Our second question states, a patient is in treatment for alcohol addiction and has relapsed since his last visit. The NP knows this does not mean treatment has failed, but why? A, relapse indicates pharmacological treatments are working. B, addiction is chronic, relapsing disease that takes time to treat. C, alcohol addiction is particularly difficult to treat. Or D, patients often relapse during initial treatment. Addiction is a complex phenomenon that will have causes and consequences that are unique to every individual and every individual's experience of the disease of addiction. Additionally, neurological remodeling takes time, especially during treatment. If you answered B, addiction is chronic and relapsing, a chronic relapsing disease that takes time to treat, you are correct. We're moving on to our second part. This is talking particularly about alcohol. You think about the basic pharmacology of alcohol, we understand that alcohol plays on our CNS system, and this is where we're going to see the effects. There's going to be acute effects, two in particular. There's first the general depression of our CNS and the activation of that reward circuit. Researchers long ago, for many, many years, believed that alcohol simply dissolved into the neuronal membrane, and there at that place was disrupting the order and the arrangement of the membrane phospholipids. But now we know from current research, more updated knowledge, that alcohol interacts with specific proteins, receptors, ion channels, enzymes that all regulate our neuronal excitability. And these target proteins that we need to pay attention to in terms of alcohol are the GABA receptors, the receptors for glutamate, and the 5-HT3 subset of receptors for serotonin. The depressant effects of alcohol actually result from the binding of these receptors for GABA, which is the principal inhibitory transmitter in the CNS. And the receptors of glutamate. Remember, this is the one that is involved in the major excitatory transmitters in the CNS. When they bind to alcohol, it's going to enhance the GABA-mediated inhibition, which then is going to cause that widespread depression of CNS activity. When alcohol binds to glutamate, the receptors, it blocks the glutamate-mediated excitation, and therefore it's going to reduce your overall CNS activity. We also have a reward center. This is found in the 5-HT3 receptor in the brain. When these receptors are activated, they promote release of dopamine, the major transmitter that we know is part of that reward system. And when alcohol binds to these receptors, the 5-HT3, it's going to enhance that serotonin-mediated release of dopamine. And this is what's going to intensify what we call that reward process. So the next time you have a drink or a cocktail, think about the pharmacological, pathological pathway of alcohol. Now, the depressant effects of alcohol, they are dose dependent. And so when your dosage of alcohol is low, or the amount, then your cortical areas are primarily affected. But as you start to increase that dose, it starts to affect the more primitive areas like the medulla. When that depression of cortical functioning, thought process, and your learned behaviors are altered, this is when inhibition starts to become released. So you lose that self-restraint, and that is going to be replaced by increased sociability and expansiveness and personality. And this all, of course, is general speaking to most patients. When your cortical areas, so the higher brain centers, are depressed, this is going to impair your motor function. And as the CNS depression deepens, your reflexes are going to diminish. You can see this on physical exam. Your consciousness actually becomes impaired, and at very high doses or very high amounts of alcohol, this is going to produce a state of general anesthesia. Now, it's not enough to be used as general anesthesia though, right? Because you would have to take lethal amounts of alcohol to actually be used as like a surgical anesthetic. There's also some chronic effects that you want to remember. When you consume alcohol chronically or in excess, they can actually produce severe neuro and psychiatric disorders. It produces injury to your CNS by direct actions of that alcohol. You also can have nutritional deficiencies, and we see this pretty often in chronic and heavy drinkers. So there are two neuropsychiatric syndromes that are very common. The first one is Wernicke's encephalopathy and Korsakoff psychosis. And both disorders are caused by a thiamine deficiency. So poor diet and alcohol-induced suppression of thiamine absorption is occurring in both Wernicke's encephalopathy and Korsakoff psychosis. So first, you think about Wernicke's encephalopathy. You have confusion, nystagmus, abnormal ocular movements. It is readily reversible if you replace the deficiency. So there's a thiamine deficiency, you will replace with thiamine. Korsakoff psychosis, you'll see polyneuropathy. The inability to convert your short-term memory into long-term memory, and a lot of confabulation, right? Remember, confabulation is unconscious filling of gaps in the memory with fabricated facts and experiences. Korsakoff psychosis is not reversible. You can't just give thiamine and reverse these symptoms. Remember, Wernicke's encephalopathy, reversible with thiamine. But perhaps the most dramatic effect of long-term excessive alcohol abuse or consumption is what happens to the cerebral ventricles. They get enlarged in response to atrophy of the cerebrum itself. And so these gross anatomic changes are associated with impairment of long-term memory, intellectual function. Now, let's say someone chooses to stop drinking. Your ventricle enlargement and cognitive deficits could be partially reversed, but only in some individuals. But you can't fully go backwards. Now that we understand the problem and how it affects the body and the mind, think about the solution. And there are some, or treatment solutions, and there are some treatments that are pharmacological. So in the U.S., there's about 1 million people with this dependence that seek treatment every year. And even though there's only about a 50-50 rate of relapse versus recovery, we still try these treatments. And so the objective of treatment is really to modify the drinking pattern. It is not going to completely eliminate alcohol consumption in most cases, but hopefully if it doesn't, at least we can reduce alcohol consumption. Obviously we want to eliminate. But there are some drugs that can be prescribed to help, and they help in a couple ways. First, they facilitate withdrawal, and secondly, they can maintain abstinence after withdrawal has been completed. And the management of withdrawal really depends on the degree of dependence. If dependence is mild, maybe withdrawal can be accomplished in just an outpatient basis and you won't need drugs. But when dependence is great, you may have to have a withdrawal protocol that includes inpatient because there's a large risk of death when there's, dependence that is really magnified. And pharmacological treatments or drug therapies, they're going to be indicated. And the goal for this is to minimize the symptoms of withdrawal, to prevent seizures, delirium tremens, and all of the signs and symptoms that go with that. And we're really trying to facilitate that transition to a program to help maintain abstinence. So in theory, any drug that has a cross dependence with alcohol, so any of the general CNS suppressants, is effective in the treatment of alcohol use abuse. However, in actual practice, what we typically will do in real life is use the benzodiazepines. They really are the drugs of choice, and I'll show you in the next slide why they have to do with withdrawal. So these are the other medications and therapies that also can be used to help someone in withdrawal. Here you can see the benefit of using a benzo is that it's going to decrease the withdrawal symptoms. It'll stabilize the patient's vital signs while they're going through withdrawal. And again, we're hoping to prevent seizures and delirium tremens. We can also use beta adrenergic blockers. This also improves vital signs. It can help to decrease that craving for alcohol, and it decreases the autonomic component of what happens with withdrawal. Clonidine is something that can be prescribed. This decreases the autonomic component as well. And carbamazepine, this also will help to prevent seizures and withdrawal syndromes. Now we're moving on to nicotine and smoking. When we're talking about nicotine addiction, we're really talking about what is happening at the nicotinic receptors. Now, whether these receptors are activated or inhibited is going to depend on the dose of nicotine or how much nicotine is being used. So low doses will activate the nicotinic receptors, but high doses will actually block them. And that amount of nicotine that's received from a cigarette is actually pretty low. So cigarette smoking is causing receptor activation. And nicotine can activate the nicotinic receptors at different locations, several. Most are going to affect at the autonomic ganglia and the adrenal medulla. And so in addition, it's also going to activate at the carotid body, the aortic arch, and the central nervous system. So heart and brain as well. And we will talk about this a little bit later, but it will mimic or cause CNS mimicking of cocaine and other highly addictive substances. When present at levels produced by smoking nicotine, it has no significant effect on the nicotinic receptors of the neuromuscular junction, however. The pharmacologic effects discussed in this part of our presentation are going to be associated with very low doses of nicotine. And these effects are going to only, the effects that we're talking about, this is only with cigarette smoking. Now, there are responses to high doses, but we're going to talk about those later when we talk about acute poisoning. So let's get into the cardiovascular effects first. At the cardiovascular level, primarily there's an activation of the nicotinic receptors in the sympathetic ganglia, the adrenal medulla, and it's promoting the release of norepinephrine from the sympathetic nervous system. Therefore, you're going to get a release of epinephrine and a little bit of norepinephrine as well from the adrenals. Now, norepinephrine and epinephrine, they act at the cardiovascular system as a vasoconstrictor. They're going to constrict your blood vessels, which will accelerate your heart, and it will increase the force or the contractility of the ventricles. So what is the net result? You will have high blood pressure and an increased cardiac workload. And this is why it affects the underlying cardiovascular diseases and death. Now, on the GI system, it's functioning primarily because it's activating the nicotinic receptors in the parasympathetic ganglia, thereby secreting gastric acid, and it can also augment your GI tone and motility of that smooth muscle. It can promote vomiting as well. And this vomiting is really resulting from a very complex process that involves not only the nicotinic receptors in the aortic arch, but also the carotid sinus and the CNS. Now let's talk about the central nervous effects. We know that nicotine is a CNS stimulant. It's going to stimulate the respirations. It's going to produce an arousal pattern on an EEG if you hook a patient up. And you can watch their electrical conductivity of their brain. In moderate doses, it can actually cause a patient to have tremors. And at very, very high doses, it can cause convulsions. We know that nicotine has multiple psychological effects. It increases your alertness. It can actually facilitate memory and improve cognition, reduces aggression, and suppresses your appetite. However, it also promotes the release of dopamine, and nicotine activates that pleasure system that's located in your brain. And that effect of nicotine on that pleasure system is pretty identical to other drugs that are addictive, like cocaine, amphetamines, and opioids. What happens during pregnancy? During gestation, it can harm the fetus. After the baby is born, it can be passed through breast milk, which can harm the infant. And because pharmaceutical nicotine is safer than tobacco smoke, it is a reasonable way or reasonable treatment plan that you can consider. What I mean is you can use nicotine therapy during pregnancy to actually help a patient to quit smoking. There is tolerance that you have to think about as well, like the other drugs and alcohol. So when you have a patient that you want to treat for smoking cessation, you can use nicotine replacement therapy. Cigarettes are highly addictive, and so giving them up is very hard. And most of our patients, they don't want to talk about it during their clinic visit or their hospital visit. However, we have to let them know that it can be hard, but abstinence can actually be achieved. Every year, about 41% of Americans make an attempt to quit, or they actually are able to quit. Now, how many are able to quit? With formal help, 4 to 7 actually will have long-term success. What does this mean? Well, there's a combination of counseling and drug use as well. So what I'm talking about is drug cessation, or smoking cessation drugs. And there is a 6-month abstinent rate that will actually approach 25% when all of this happens. However, even with counseling and the smoking cessation drugs, that first attempt usually doesn't work. And so something to go in knowing and letting your patient understand. Most people try quitting at least 5 to 7 times before they actually succeed. And at that time, cigarette smoking can actually increase as they relapse. The chance of relapse then gets progressively smaller as they continue trying to quit. For those patients that actually can make it to their 1-year anniversary of quitting, 15% smoke again. So there is a good rate. And of those that actually can quit for 5 years, only 3% will relapse or begin smoking again. So we always talk about the health benefits of smoking cessation whenever we have a chance, and talking about the reduction of risk. So there are some benefits that applied to most people, like the young, the healthy, and people who quit after the age of 65. We want to really promote and establish that there are going to be tobacco-related diseases, but you should still smoke. Like, think about people that have COPD. Well, we don't just say, well, now that you already have COPD, don't worry about it. You already have COPD. We're still promoting the cessation of smoking for obvious reasons, right? So, think about the 7 drugs that you can use and try to remember them so that you can actually promote them and put them into practice. You can see them on the next slide, but, of the 7 products, 5 contain nicotine. They're nicotine-based products like nicotine gum, nicotine lozenges, patches, inhalers we also have nasal sprays, and we also have nicotine replacement therapy, or NRT. There are 2 drugs that are nicotine free. We have sustained release bupropion. We also call it Zyban. And we have varenicline, which most of us know it as Chantix or Champix. These are 2 drugs that if they don't want nicotine at all, you can prescribe, and they are prescribed often. We take them to decrease that overall craving and to suppress the symptoms of withdrawal. And the most effective drug therapies for smoking cessation are either Chantix alone, or you can use it in combination with the nicotine patch. And this is going to help promote the chance of smoking cessation. And you can even use it with a short-acting nicotine product like a gum or a nasal spray. We don't have enough information. It has not been studied widely enough to predict who will respond to what particular treatment or product. And so really it's based on patient preference and what is available and what they've used in the past, and also, what is causing side effects. And here you can see in this very tiny table the pharmacological properties of each of these products, the common side effects. With the patch, some patients complain of burning and itchiness under the patch, and this can happen with any type of transdermal medication. Some people actually complain of insomnia with the nicotine patch. There are some advantages. You can get it over the counter, and there are studies that have shown that it's easy to use, it's unobtrusive, and it does have its ability to help patients stop smoking. The disadvantage is that you can't really adjust the dose. So it's not like if a craving occurs, you can go home and put like another patch on, and then that automatically it's going to help you reduce. So this patch is going to be released more slowly than the other products, and have just a more leveled out level of nicotine. The gum, some people don't like how it feels on their throat. Some people think that it increases jaw pain, and it has to do with chewing gum all the time, and also causes a lot of burping or dyspepsia. Advantages is that it's non-prescription and over the counter, and the user has a little bit more control of how much they want to use. They need a little bit more, they can chew more gum. They don't need that much, they can chew less gum. But there are some disadvantages. It doesn't taste very well. You saw on the other slide, there's some that are trying to mask the taste by using things like cinnamon to help with that. If you're chewing all the time, we already saw it can cause jaw pain, but you can't eat or drink while you're chewing the gum, obviously. I mean, you can, but it doesn't go over well. It can also damage any dental work or dental appliances that some people wear. So think about, people that use dentures or have crowns or things like that. Chewing gum all the time may not be the right thing for them. There are 2 milligrams in each piece of some doses, and then we also have a 4 milligram piece as well. So how you decide whether you're going to use 2 or 4 depends on how many cigarettes they were smoking per day. And you can see if they were smoking and they have a low to moderate dependence. So think about someone that has 25 cigarettes daily. You might start with a 4 milligram piece, and someone that has they're barely smoking, maybe like 1 or 2 cigarettes, or maybe 5 cigarettes, you might go with that 2 milligram. You don't want to go over 12 pieces a day. using it longer than 6 months is also not recommended. So you want to make sure you're telling that your patient too. If they're using nicotine gum consistently and it's not working, then at about the 5-month mark, you start thinking about other treatment options. You can use they're like cough drops, but they have nicotine in it. You can use the lozenges like Nicorette. I'm sure you've heard of that. There's other brands called Thrive. People that take it, my patients have complained that it makes them very burpy and it irritates their mouth. Some people say it can also make them a little bit nauseous. It is over the counter as well. They can control it like the gum. They have, again, 2 milligrams and 4 milligrams. And again, it depends on how many cigarettes they were using before, and this will kind of help you determine the dosing. That first cigarette, 30 minutes or more after walking, you want to use 2 milligrams. If they're getting their first cigarette within 30 minutes, waking, first cigarette within 30 minutes of waking, then 4 milligrams. So basically, if that's the first thing on their mind, you want to dose them a little bit higher. You also don't want to use more than 5 every 6 hours, or you don't want to max 20 a day. And this is something that you can use about 3 weeks or so, and 3 months or so, and if it's not working, then you want to try something else as well. With the nasal sprays, sometimes there's a lot of irritation initially in that first week. I say, hey, if you can power through, and if you're still having these symptoms in week 2, we'll try something else. You can have a lot of success with the nasal sprays, but it is something that is not over the counter, and you're going to prescribe it. They're 10 milligrams, and they're in a sealed cartridge, and you want to think about frequent puffing over 20 minutes if you're going to prescribe this nicotine spray. And usually they go through 6 to 16 cartridges a day. So after 3 months, if they're not able to taper and feel like they're getting results, then you can go for another 2 to 3 months and then stop. So a total of 6 months. There is a nicotine inhaler, also causes similar symptoms as the nasal spray. And with the nicotine inhaler, it mimics that hand-mouth motion of smoking, and sometimes there's a psychological effect from that motion. You need a prescription, slow onset and low nicotine levels. You have to do frequent puffing of this device, and there's 0.5 milligrams per activation, so every little puff that you're spraying. You put it in the nostril 1 to 2 times per hour, and no more than 40 doses per day. And so after 6 weeks, you start to decrease the use and continue to decrease the use. So those are all the products, of smoking cessation drugs that have nicotine. And so for the 2 that don't have nicotine, Chantix and Zyban. For Chantix, most people think that it causes insomnia or sleep disturbances, headaches, nausea. Some people will complain of abnormal dreams while they're on it. It's a very common side effect. It's easy to use because it's a pill. There's no nicotine, and there's a prescription that is required. So you have to write a prescription. It's 0.5 to 1 milligram tablets, and it's considered the most effective pharmacological aid for smoking cessation. If you give the 0.5 milligrams, it's PO daily for 3 days, and then you move on to twice a day for 3 days, and then 1 milligram PO twice a day for the rest of the treatment, a total of 12 weeks. If abstinence is achieved, an additional 12 weeks of treatment is warranted. You still want to keep going, and you're going to go at that 1 milligram PO BID. With Zyban, you might get insomnia, dry mouth, agitation. It's also a pill, so it's easy to use. Sometimes with our patients, it promotes weight loss as well, and it will actually limit that sensation-related weight gain that a lot of cigarette smokers will experience because they no longer have that appetite suppression. It is the first drug of choice that we use with smokers that also have depression because it's bupropion. And you have to prescribe it 150 milligrams extended release tablets. So because it's extended release, you can take it daily for the first 3 days, and then you're going to ramp up and take it twice a day from week 7 to 12. And after that, you're going to start to decrease the usage. So try to be familiar with these dosages, and think about what route and use is best for your patient. And we are going to wrap up this conversation talking about other drugs that can be considered abused. We've talked about the pharmacology of opioids, but now we're going to talk about it in terms of opioid abuse. You think about heroin, oxycodone, there's other drugs. Oxycodone is also called Oxycontin. And sometimes it's first introduced through recreational use, and other times it's because there was a medical problem. Usually it's because we're trying to help reduce pain or manage pain, and then it becomes something that they're taking in a compulsive manner. So it becomes drug abuse. And think about with heroin, the draw is that it gives this immediate rush or immediate kick followed by a prolonged sense of euphoria. And because of that, it becomes a primary reason for overall opioid abuse or heroin abuse. And you can see this if you take oxycodone, for example, and instead of swallowing it like most of users, they are crushing them, snorting it, they're putting it and dissolving in water, injecting it intravenously, getting that rapid absorption. And because of that, we're seeing dangerously high levels of this opioid in the blood. And this is what is associated to overdose. We also have that risk of respiratory depression that happens, and greatest in people who have not developed a tolerance to opioid. It's that depression of the respiratory system that causes death and overdose. And so for long-term use of opioids, it can then produce a substantial physical dependence as well. And so there's abstinence syndrome that you have to think about, and withdrawal. And you want to think about, once that withdrawal or acute withdrawal or abstinence syndrome starts to fade away, about 10 days, most opioid addicts are going to have a milder but protracted phase of withdrawal even following, and this can persist for months and months at a time. And so they will still have insomnia, irritability, fatigue. There's some GI hyperactivity that can also occur, and sexual dysfunction as well, like premature ejaculation. We do have treatments though for the reduction of acute toxicity. So overdose produces a classic triad of symptoms. We have respiratory depression, coma, pinpoint pupils. You can use Narcan, naloxone. This is an opioid antagonist. This is the treatment of choice when we see this type of toxicity. We also can use methadone for those patients that are going to need longer term help with their drug abuse, and there's long-term management that's needed. We can use an opioid agonist called methadone. We also have an agonist-antagonist, buprenorphine, that we can use too, and these substitute that abused opioid, and we're giving them this to patients that aren't ready to detox completely. We can also use naltrexone, which is an opioid antagonist, and this is to discourage that renewed opioid use, and at least until just detoxification can happen, so when they're fully detoxed. If you use methadone, you really need to monitor your patients, and so you can use it to initially help with the withdrawal symptoms, but also for maintenance therapy as well. And when you have the methadone maintenance, you're really transferring that addict from abusing the opioid now to this oral methadone that you're going to be prescribing. And so hopefully it helps them with withdrawal, but also that need to get or illegal drugs while they're taking methadone. So how do we suppress these symptoms? Well, the addict progressively is going to get larger doses of methadone until they get to 120 milligrams per day, until that's reached. And then they build off of this dose until they get a high degree of tolerance. And then, once they get no effects experienced with the methadone itself. Because there's cross tolerance that exists among opioids, after the patient becomes tolerant to methadone, when you start taking high doses of other street drugs, you're not going to produce that significant desirable effect that they used to get. So for instance, if they've reached this max dose, this high dose of 120 milligrams a day of methadone, if they go for heroin or OxyContin, you're not going to get that effect they are searching for from before. And as a result, individuals become more tolerant with the methadone. They're less likely to seek out illicit opioids, right? So we're trying to get them to a methadone tolerance. The use of methadone to treat opioid addiction is restricted to only opioid treatment programs that are approved and designated by state authority. So as a family practice provider, you can't prescribe it. You can't prescribe this in urgent care. You have to refer or become someone that is approved to treat in a facility that is certified by the Federal Substance Abuse and Mental Health Services Administration. These restrictions on the non-analgesic use of methadone are needed to control the abuse of methadone, a Schedule II drug. Right, and it does have the same abuse liability as morphine and other strong opioids if not monitored. You can use Suboxone, which is the buprenorphine. This is an agonist-antagonist opioid that works partially on the mu receptor and is a full antagonist on the kappa receptor. And so we can also use this for maintenance therapy, and also it helps to facilitate detoxification as well. But unlike methadone, which is only available, remember, in these certified opioid treatment programs, Suboxone can be prescribed, and the prescriber must have received at least 8 hours of authorized training by the Substance Abuse and Mental Health Services Administration. They have to be registered with this organization. It is a partial agonist at the mu receptor, like I said, so it has a low potential for abuse, but it can suppress the cravings for opioids, so this is why we like to use it. Now, if the dosage is significantly high, then it can completely block the access of the strong opioids to the mu receptor, and thereby, if you try to abuse the opioids like heroin and OxyContin, you're not going to get that same euphoria from before. There is a ceiling with this medication to respiratory depression. So therefore, what that means is that it's safer to use than methadone, and that's why you can prescribe it outpatient if you have been trained to do so. Physical dependence is lower, and so the withdrawal from it is relatively mild. There are some formulations that are provided, like sublingual tablets. You can also order solutions for sub-Q injections, subdermal implants as well. And there's different formulations for these methods of administration. The other thing, there is a newer type buccal film, so you just put it inside the lining of your cheek, called Bunavil. And when you put it in your cheek, you can actually get long-term maintenance. And you don't want to use naloxone in someone that's taking this medication because the reason is because there's a use, usually it's to discourage that IV abuse, and so you don't want to give naloxone to this patient. So using these other methods is more reasonable. If taken intravenously, the naloxone in the Suboxone will precipitate the withdrawal itself. And so sublingual administration, also, there's very little naloxone that's absorbed, and so then the drug is administered as intended, then there's very low risk for withdrawal. The last one is naltrexone. It's marketed under Vivitrol, and we use this during opioid detox, and it is a pure opioid antagonist, and it has discouraged the abuse of opioids. And how it does this is it will block euphoria altogether. And so if you try to take any other opioids, you're not going to get that same effect. You're not going to get that pleasurable kick or rush that you did when you were using heroin or Oxycontin. So it's going to eliminate that reinforcing property of taking that drug. And former addicts actually learn that if you use an opioid, it's not going to give you what you want. And so it's going to help bring down that drug using behavior. Now, naltrexone is a controlled substance, so we can actually prescribe naltrexone, and we don't need any special treatment or training or certification. We just need to be licensed prescribers. It can be given orally or intramuscularly, and you give it once a day. The IM injection is called Vivitrol, and it's only given monthly. There are other drugs that are a little bit less popular, like Crantum. And this is actually a tree that's grown in Southeast Asia. It's composed of two compounds that interact with the opioid receptors in the brain that produce euphoria. So it's helping to decrease that feedback. And so it is not a scheduled drug currently, so it can easily be purchased over the internet or local shops in forms of capsules, liquids, and powders. And many people actually use Crantum for pain relief and as a substitute for opioid therapy as well. So there are some anecdotal reports that suggest that Crantum is safer than using opioid for pain, and it's less addictive. However, the DEA is still investigating the overall use and considering moving its category to Schedule 1 because they feel that it can cause imminent hazard to public health. So there's lots of controversy over the use of Crantum. So right now the DEA is not allowing the public to use this at this time in the US.